shunts the greater part of the blood from the right ventricle directly into the descending aorta to supply the abdomen, pelvis, and lower limbs of the fetus. The hypogastric arteries, which are extensions of the internal iliac arteries, carry blood back to the placenta, where more oxygen and nutrients are supplied from the maternal circulation. So from what I have shared so far, it is clear that in a fetus, there's mixed blood. Then we have these shunts that we have talked about that makes the fetal circulation to be very distinct and not equal to the adult circulation. So if we understand what goes on in the fetus, we are going to ensure that at delivery, that golden minute, we really see that what is happening, because we are going to understand the adaptations that happens when the baby is just born. So we'll move to the changes at birth. What happens? Because we have seen what is happening in utero. Now this baby, it's 9 months and it has to come out. So what will happen when the baby is born? The infant will cry and expand the lungs, causing an increased flow of blood through the 4 pulmonary veins into the left atria. So this equalizes the pressure between the atria. Remember, between the atria, there was the foramen ovale. And now when the baby is born, the foramen ovale is not necessary. And because of the equalizing of the pressure, it is going to close functionally. It's going to close because those functions now that it was performing while in utero, this baby has come out, and the lungs are going to take up the responsibility of gaseous exchange. So the foramen ovale will close so that there is no connection now with the blood that is in the right atria and what comes in the left atrium. So with the establishment of respirations, blood is oxygenated in the lungs, and the lungs now become functioning because you have clamped at the first thing that happens when the baby is born. Wupe always talks of we wait for 3 minutes, which is a very good thing. But when we just clamp, just know that we are stopping what was happening. What will become of that placenta, the umbilical cord? What remains is now for inspection for that organ, but the functions that the placenta was performing with the umbilical cord now will cease. The umbilical cord ceases to conduct oxygenated blood to the fetus and deoxygenated blood back to the placenta, because the lungs now, the baby has taken the first breath. The lungs, the air sacs have recoiled. So now you see that when the baby cries, blood will now flow into the lungs. So the umbilical vein, ductus venosus, and the hypogastric arteries are now no longer necessary and fibrose to form supporting ligaments in the abdomen and pelvis. Through the first few centimeters of the hypogastric artery remain patent and become part of the superior vesical artery. By the end of the first week of life, the fetal end of the cord should have dried within 7 days and separated from the skin of the newly born infant. The ductus arteriosus contracts as the lungs expand, but does not always close immediately. So there's a permanent closure and the functions really not happening when the baby is born. The ductus arteriosus contracts as the lungs expand. Remember, the ductus arteriosus was a shunt near the pulmonary artery. Instead of the blood going to the lungs, the blood was being shunted to come down to the descending aorta, so that the lower part also of the fetus is well taken care of. So it gradually fibroses to become a supporting ligaments in the thorax. So what are these permanent, at the end of it all, those structures, the temporal structures that were there, what do they become at the end of it all? The umbilical vein becomes the ligamentum teres. Remember, the umbilical vein was bringing oxygenated blood from the placenta, and some of it was going straight to the liver, while a good chunk was being diverted by the ductus venosus to go into the inferior vena cava, and the blood now mixes there. Then also we have the ductus arteriosus, which becomes the ligamentum arteriosum, a shunt at the pulmonary artery there. Then the foramen ovale becomes the fossa ovalis. The valve was the one which was connecting the two arteries. Now it will close and it will become the fossa ovalis. Very common questions in exams for our students. We need to know, because it's very easy to say the umbilical vein becomes the ligamentum arteriosum. So we need to understand the changes. For us to understand, let's start by understanding the adult circulation, what happens in an adult, so that when we hear about these temporal structures, we are able to apply, oh, this is really what happens to this special being that is in utero. The hypogastric arteries become obliterated, hypogastric arteries, except for a few centimeters, which remain open, and they are now known as superior vesicles. So that was a bit on the fetal circulation, because it's not like a detailed lecture, but discussion, so that we know where people understand, especially the students, and where they don't understand, and people on the call who help to answer the questions in case there will be any questions. So who needs, at least at your own time, practice how to draw the diagram of the fetal circulation. Describe the fetal circulation in detail. Outline the adaptation that happens to extrauterine life. Very, very important. Kennedy, I end here. If there are questions, discussions, please feel free. We have a lot of gurus on call who take up those questions, and I'm sure Secretariat will share the presentation in case you want to revise. Thank you so much, Kennedy.
Thank you so very much. You can still post the questions, okay. The questions part. So thank you so much for the presentation. Do we have any clarifications or questions? We have icons that we can use. You can raise your hand. When you go to reactions, I think there are icon that you can use to raise your hand. So those who want to maybe have contributions, you can equally do the same. Probably you can start with contribution. Any further contributions?
Yeah.
Any questions? We seem not to have any questions still. Any concluding remarks, Madam Esther?
Oh, okay, so because I'm sharing, I can't see whether there are questions or hands. So if there are no questions or contributions, it's either it's not clear at all, or it was very clear. But I would appreciate, I think, 3-4 comments before I conclude. Kennedy, check in the chat if there's something, and if people have to, they may add. I may have left out very important points. I think right, being so quiet will not help us.
There's a comment maybe from Charity. She says, I'm using Charity's phone. I'm a student midwife. My question is, why do we need to wait for 3 minutes before clamping? So that's a question coming from one of our students here.
Okay, I'm sure Kennedy, you're able to take that one.
No, you can pick it up.
There's you remember there's still what we're told is that there's still some blood that remains that will help this baby if we delayed clamping. Yes, what is being promoted is delayed clamping. So when you clamp, it means that there's no more blood that is going to the baby, but when you delay, you have more blood, and we are going to improve the HB of this baby. Already, you know, in utero, the HB is higher because it has high affinity for, stop disturbing me. So mostly it's just to add more blood to the fetus and prevent the anemias that may come in these babies. That's what we were told in the presentation of delayed clamping. Maybe next time we can also do the delayed clamping presentation. Thanks.
Thank you very, very much. There is another comment. Firstly, it's just an appreciation from Simukonda being in service. That's a very good revision. Then there's a question from Trinity. Says, you said the cord should fall within 7 days. What happens if it reaches 14 days and it hasn't fallen? Thank you. So that's a question coming from Trinity. Can take it up.
Okay, so you know, the cord falls by a process of dry gangrene, and we expect that, but by 7 days, that is, it falls off. If if it doesn't, and it's not showing any signs of infection or that there's a problem, I think that wouldn't really be cause to worry. But if you see that maybe there's some inflammation, there's some red going on around the cord, and maybe some pus, something that we are not expecting, I think it would be good to seek medical attention from a midwife who is a specialist in this area or an obstetrician. Otherwise, the normal that has been studied every day says that but within 7 days, I think we need to see that drops off. So unless there are problems that will affect the baby, then it becomes a challenge. Probably infection, inflammation. How are they? Sometimes it's how they clean that umbilical stump that brings in a problem, which will take us to another topic. Thank you.
Thank you so very much. There's another question, just a concern. Presentation was excellent, but Madam was too fast. That's from Tama. We will share the recording. This session is being recorded, so at your own time, you can listen to it. The other one is from Whitney. She says, why are we adding more blood when they say an infant is born with high HB of 16 to 22 grams per deciliter? That's on delaying. I think this is in relation to the issue of delayed cord clamping. And then the another question, I think submission is that this is, she just wants to say that this has been very educative session, and she hopes it's not the very last one. It's not the last one indeed. This is just a beginning, and this is the very first of these sessions. So I think maybe on that one, maybe there is another submission from unknown. We delay in clamping in case there is need to resuscitate the neonate. So that's just in addition. But the other question is, why should we delay? I think the answer has been given already. There's a hand from Mwerwa Chudu. You can proceed, please. Mwerwa. You can talk. Let's go to Grace.
I think I had a contribution.
You can proceed.
On the issue of why should we add more blood to a baby who has just been born with the high HB. We know to say in utero, the baby had the high HB so that it can get more oxygen for itself. So the reason why we also add more blood, we know to say after delivery, the baby, because of its high HB, there will be blood distraction so that it goes into an adult, it has an adult hemoglobin. Therefore, if the baby already, when it's being born, it has low blood and there is that distraction of red blood cells, it will also have anemia. So before we cut, we allow it to have more blood so that even after blood, there is red blood cell distraction, it will still have enough hemoglobin levels. That's what I had to contribute. Thank you.
Thank you, Grace. We can proceed to Priscilla. Priscilla or Charity. Then after that, the presenter will make, I think, contributions.
Hello, good evening.
Good evening, thank you.
Yes, I think just a comment on the one who indicated that we do delayed cord clamping for resuscitation purposes. I think it was clearly indicated that we want to allow enough blood to get to the baby and not for resuscitation. So I think that one should be clarified so that we don't see those points students raising in their essays. So clearly delayed cord clamping is to allow enough blood to get to the baby, which has higher advantages of raising the HB to reduce on the physiological anemias that take place after birth. Thank you. I submit.
Thank you, Priscilla. There's also a comment from Wedwa. She couldn't speak through. She has network challenges. I think it's just a further emphasis on as to why we have this delayed clamping. Madam Presenter, please, can come through.
Okay, so thank you very much for there's one who mentioned that I was fast. I think I'll try to do better, but I think even you're not the first one. I think even during evaluation, sometimes when I was teaching, my students will say like, you are fast. So I'll try to relax next time that I pick another topic. Thank you for bringing, I love evaluations. So I was just reading somewhere where it is saying delayed umbilical cord clamping is associated with significant neonatal benefits, and it includes improved transitional circulation, better establishment of red blood cell volume, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis, and also intraventricular hemorrhage. When you give it more blood, you delay, you are going to prevent some of these things like intraventricular hemorrhage. So thank you so much for attending, and we've been promised that it's not the end, we are just beginning, and privileged to have been the first one to present on fetal circulation. In conclusion, what we want to say is for us to understand the fetal circulation, understand the adult circulation first, and also know about the shunts that are in the fetal circulation, understand how the blood moves from the placenta to the baby, and why we have mixed blood in the fetus. These shunts, what are they doing? All that is for you. The presentation is like we are enticing you to read more so that you understand the fetal circulation better. Thank you so much, and we hope to see you again with other topics. It was a pleasure. Thanks, Kennedy, and thanks, Maz Executive, and all senior midwives on the call, and all middle student midwives. I appreciate you.
Thank you so very much.
Thank you so much.
So thank you. On Wednesday, just an announcement, a quick one. On Wednesday, we're having another presentation at 16 hours to do with postpartum depression. It was indeed a wonderful presentation, and a good evening to all of us.
Thank you so much. Bravo.
Thank you.